Welcome back to the Healthcare Triage Podcast. This Healthcare Triage Podcast is sponsored by Indiana University School of Medicine, whose mission is to advance health in the state of Indiana and beyond by promoting innovation and excellence in education, research, and patient care. IU School of Medicine is leading Indiana University's first grand challenge, the Precision Health Initiative, with bold goals to cure multiple myeloma, triple-negative breast cancer, and childhood sarcoma, and prevent type 2 diabetes and Alzheimer's disease. And that's perfect because today we're going to be talking about multiple myeloma. Our guest this week is Rafat Abonour, who's the director of the myeloma program at Indiana University School of Medicine. We're going to be talking today about multiple myeloma and where the cutting-edge research is, what people are doing, what people are thinking, where we might be going. So welcome. Thank you for joining us.
Thank you for having me.
Can we start a little bit? We're always interested in hearing about the backgrounds of our guests. How did you get to this position? How did you get interested in your research? How did you get here?
So I started wanting to become a transplant surgeon, but then I ended up doing just a hematology fellowship and bone marrow transplant. And I did my research on plasma cells. These are the cells that cause multiple myeloma. And then I started doing gene therapy, and gene therapy wasn't exciting and dangerous, so I needed to focus on something. So I knew plasma cells, and I loved myeloma patients, so I decided to focus on that.
So let's say, what are plasma cells?
So plasma cells are the cells that make antibodies to help us fight infection. We need them. That's how we survive, 100 years, 70 years, whatever. So what happened is that one of these plasma cells become malignant and start reproducing itself and causing harm to the patient.
So they're a type of white blood cell?
Yes, sir.
Okay. Where are they made?
Well, they actually start in the lymph nodes and then they migrate to the bone marrow where they reside, So you get your first sort of encounter with, for example, let's say tetanus or, pneumonia bacteria in the blood. And then these cells, mature, become plasma cells, produce memory antibodies to help us fight infections as, when we get exposed again to the pneumonia. And they reside in the bone marrow. When we need them, they get out, they make more new antibodies to help us fight infection.
So can you talk a little bit more about how they work when they're working right? How exactly do they help us fight infection?
Well, they produce a specific antibody. So we have a repertoire of plasma cells that are capable of recognizing different pathogens, from the mumps to the measles to the influenza to the pneumonia. And so every time we get exposed to one of these pathogens, these plasma cells proliferate and produce more antibodies to fight the infection.
And so what happens when they produce the antibodies? What happens next?
Well, the antibodies bind to the pathogens and you just neutralize it or, help other cells gobble it up.
Okay. So what happens when things go wrong?
Well, when things goes wrong is that one of these plasma cells start accumulating in the bone marrow. So you initially have, for example, maybe 5% of abnormal plasma cells in the bone marrow. They don't cause any harm. We call that condition MUGUS, monoclonal gammopathy of undetermined significance. You just have a monoclonal protein, doesn't cause harm to the patient. But what happened next is that tons of these cells start, accumulating in the bone marrow. So you have like 10, 20%, but it's still not causing harm. So we call that condition smoldering myeloma. And then eventually what will happen is that these plasma cells can affect the patients in different ways. One is that it can weaken the bone. So about 70% of patients with myeloma will have either osteoporosis, holes in the bones, or they start breaking bones. So they have they just try to lift a bag, and then they break a bone in their back or something like that. So myeloma can affect the bones, can cause anemia, can cause very high calcium level because you're leaching calcium out of the bones, so the patient become unable to think and may go into a coma. Or they can actually get kidney damage. So we call these sort of the CRAB criteria for diagnosing myeloma. The C is for high calcium, the R, renal or kidney failure, A, anemia or bone disease. So you have a lot of these abnormal cells in the bone marrow and you have one of these criteria, then that patient has multiple myeloma.
What makes the plasma cells go bad? What goes wrong?
So a lot of research going on in terms of environmental exposures. And just this week got a big settlement against Roundup because when patients develop multiple myeloma from using that. So we think there is, toxic exposures, farming communities. There's increased risk of multiple myeloma near factories and near mining communities. For example, I have patients near a mine in southwest Indiana where multiple people who worked in that mines developed multiple myeloma, and the question is, what did they dump into the water? I mean, these people are drinking water. And so we think chemical exposure plays a role in making these plasma cells sort of become malignant and multiply and cause harm and cause disease.
Okay, so once we have a concern, they've met the CRAB criteria, what happens next to help make the diagnosis?
So we do several things. Number one, obviously, we need to do blood tests to see if they're anemic, they have high calcium, or they have kidney failure. The second thing is that we look for this abnormal protein because myeloma start from one plasma cells. The protein they produce is unique. We call it monoclonal protein. So we do a specific blood test to check for that monoclonal protein and find it. We have to find a monoclonal protein, or we find an abnormal part of that protein raised. We call it a free light chain. So we check that. The second thing, we have to look and see what they have in the bone marrow. So we do a bone marrow biopsy to see the number of these abnormal cells and what type of cells. We do genetic analysis on those cells to see what they do. Because myeloma patients, some of them do very well, some of them do okay, and some of them do poorly. And the genetic makeup of the myeloma can help you distinguish these three groups.
So that was actually going to be my next question. Are all cases of multiple myeloma the same, or are they all very different, or do they fall into a bunch of categories?
Yeah. I mean, I think the term multiple may not be really because of multiple lesions within the patients. I think it's multiple presentation of the disease.
Okay.
So I have patients who do very well. They get one kind of treatment and they go on and stay in remission forever. And then we have patients who within a year or two, they relapse and they actually don't do well. And then, so that's about 20% for each group. And then the rest, the 60%, those patients, have multiple relapses, but you can control the disease and they can live long life.
So what is the treatment for the most part?
Yeah. So the treatment has evolved. It used to be more chemotherapy or traditional drugs that cause hair loss or blood counts abnormalities. But now we have these, we call them sort of novel drugs. They work on things that influence the proliferation of the cells or their interaction with the neighborhood where they live. So these cells can, not really find hospitable environment within the bone marrow to grow. So these are new drugs that in combination have produced amazing results. We still consider high-dose chemotherapy and stem cell transplant as part of the treatment to improve the outcome. And some patient may need maintenance therapy after you do the stem cell transplant.
So for the most part, though, it's drugs.
Yes, it is drugs.
And so what's the typical course of treatment?
So most patients will require what we call induction treatment, which is trying to control the disease, trying to improve the symptoms. And that will take 3 to 4 cycles. The cycle is about 4 weeks. After that, you do the stem cell transplant, which is 2 components. One's collecting the stem cells that support the use of high-dose chemotherapy. Then you give this big-dose chemotherapy, which kills everything in the bone marrow, but you have the patient's stem cells that make blood cells stored. So the next day you give it to the patients, and these cells will grow and make healthy blood cells.
This is when you're doing a stem cell transplant, you're actually
Yes.
transplanting the patient's cells back into their own body.
Yes.
How does that work?
So what you do is you collect the patient's own stem cells first, and these cells live in the bone marrow. So what you do is you give a specific hormone that stimulates these cells to grow every day for 4 days. On the 5th day, their blood is full of these stem cells. What you do is you take the blood out, and you do a process like dialysis process called apheresis. So you collect only the stem cells, and you store them. You give the blood back to the patients. And you do this in the outpatient in the blood bank, 4 hours, 5 hours a day. Sometimes in one day you get all the stem cells you need. Sometimes you need up to 3 days.
How do you be sure that you're not collecting bad cells or that those won't turn into bad cells?
Yeah, so we have looked, actually, we did research on that. So what we're looking for is specific marker on the surface of these cells, makes them stem cells called CD34. And we looked to see if we collect any myeloma cells, and we did very sensitive assay. And two things. One is that the myeloma cells don't mobilize, that effectively. And the second thing is that they don't freeze well. So basically, the products we give back to the patients, very unlikely to contain any myeloma cells.
Knowing that the stem cells could then, are you assured that the stem cells won't then develop into cells, which will turn back into myeloma, or is that just, you just have to take the
So
risk?
the stem cells are the cells that make white cells, red blood cells, and platelet.
Right.
And the process of developing multiple myeloma doesn't really start at the stem cell level.
Okay.
It start probably around, when they sort of mature to white cells and before they divide into lymphocytes or neutrophils, different part of the white cells. It's at the lymphocytes level. When, they become B cells, the B cells become plasma cells. So maybe it's between the B cells and the plasma cells.
So I guess and this question may be totally naive. Given that we know that whatever was in this person that's such that their cells could develop into myeloma cells, would they be better off with someone else's stem cells in the sense that those cells are less likely, or is that just too hard to do?
Well, it's very hard to do. So we have done what we call allergenic transplant,
right?
Donor stem cell transplant. The problem is that most patients with multiple myeloma are in their late 60s. So allergenic transplant is very risky. We actually lose a large number of these patients. And despite doing an allergenic transplant, some patients have relapsed. So it's not really a routinely used approach. Maybe in the young patients, and you may consider an allergenic transplant. The issue with allergenic transplant is the risk of a graft versus host disease. The immune cells from a donor do not like where they're living in the patients, so you get damage to the skin, liver, and the intestine. But the other thing is that the advantage of allergenic transplant used to be the graft versus disease. Unfortunately, the myeloma cells tend to hide from the immune system, and we don't get a very good graft versus myeloma effect when we do allergenic transplant.
Okay. So patients get a round of drugs and then stem cell therapy. What's the usual course after that?
So after 3 months later, they recover from the stem cell transplant. Then some patients are considered for maintenance therapy. So two things. One, we give them medicine to keep their bone from breaking down. We do that as an infusion or injection once a month. And then sometimes we give pills of these novel chemotherapy drugs that will help maintain the response. I think the research should be focusing on what to do after transplant when the patient have minimal residual disease. How can we improve the patient immune response to eradicate the residual disease?
Right.
Is it the chemo pill, or is it some other strategies that we are trying actually to explore here?
How many different types of drugs are available? I mean, is it that everybody gets sort of the same cocktail of drugs, or is it individualized?
So when I started working on multiple myeloma, we had only this traditional chemotherapy. In 2003, the first in-class drug was approved, which is a proteasome inhibitor. And proteasome inhibitor is, just think about it like you have a garbage disposal and you just clog it, and you just the accumulation of toxic stuff, and the cells start dying. So that's how proteasome inhibitor works. And these are amazing. I mean, these drugs have changed the course of the disease. Now there are 3 drugs in that class available. And in 2006, we got a class of drugs approved called the immunomodulatory drugs. So, and the first in class was the drug Thalidomide. That drug that caused a birth defect when it was used in the 50s, for motion sickness and nausea associated with pregnancy. And this drug, we didn't understand how it works for a long time, but it worked. So, but the problem was using thalidomide for a long time, it can cause nerve damage.
Okay.
So the company that makes that drug started developing next generation of that drugs that cause less neuropathy. We actually have 2 drugs in that class now. So we have 3 immunomodulatory drugs, 3 proteasome inhibitor. And then more recently, the FDA approved drugs, we call them monoclonal antibodies. So these are drugs that recognize the surface of myeloma cells and sort of, help eradicate these myeloma cells. So a protein that bind to the myeloma and bring the immune cells to try to eradicate them.
So how do you decide which of those to use?
Well, that's a great thing. That's why we do clinical trial.
Sure.
And in the clinical trials, we find the best combination. So first of all, now we know that one drug is not enough.
Okay.
You have to use a cocktail of drugs. And so we just, the good things for a patient today is that you have different cocktails. So based on their medical condition, you can find the right combination therapy.
So when you say their condition, what do you specifically?
So for example, if somebody has significant nerve damage, you want to avoid drugs that cause further nerve damage. If somebody have advanced kidney failure, you want to avoid the drugs that can be too toxic if you have kidney failure. So that's a good news for the patient, is that we can tailor the therapy toward their conditions, and their actually desire. I mean, some people would like only oral regimen. They don't want to go to infusion. They can't really go twice, a week to the clinic to get chemotherapy. We have oral regimens for them.
So when you say there are cocktails, is it multiple drugs in a class, or you're picking drugs from each different class?
Exactly. We pick drugs from different class. So basically what we do is synergy without overlapping toxicity.
Okay. And so what is the usual course? You have your treatment, you're in maintenance. How do most patients do?
So most people, as I told you, they really do well. They stay in remission for a long time. Now the average, time in remission maybe 5 to 7 years. But unfortunately, we have about 20% of patients who relapse within the first 2 years. We call these our high risk. Risk of what? Risk of shorter remission, shorter survival. That's where really a lot of research going on to try to improve the outcome of these patients.
So do you treat them again?
Yes, we treat them again. We try to find novel combinations. We try to find clinical trials for these patients. We're trying to employ some of the newer strategy. For example, one of the newer strategy will be what we call CAR T cells, which is basically taking the patient's own immune cells, expand them, genetically modify them to make sure that they can recognize myeloma and kill it. So we put 2 genes, one to recognize myeloma and one killer genes. So that's why we call it chimeric receptor antigen T cells, CAR T cells. So these cells these kind of therapy is now used in clinical trial in relapse patients, but we may be able now to use it in a clinical trials for the high-risk patient upfront before they get to, relapse and have a horrible disease that's hard to control.
How hard is it to do that?
So first of all, you have to collect the patient T cells with the lymphocytes that become the killer cells. So basically, it's like we collect the stem cells. We do apheresis. We take the blood out, separate the white cells from the rest of the blood. And then when you take these to the lab, to the processing manufacturing facility, you separate the specific cells, we call them T cells, and then you incubate them with a virus that get the 2 genes inside the cells after you expand these cells, and then you bring them back and take them back to the patient. So it's a very expensive process. And, the FDA, as you know, approved 2 CAR T cells, one for lymphoma and one for leukemia, that are very expensive. But there's a lot of different companies are working on it. We at Indiana University School of Medicine put together grants, and we have a center, the Brown Center for Immunotherapy. We're almost ready to recruit the director of that. And our goal is to try to improve on the safety of these products, the specificity of these products, and improve the sort of sustainability. Unfortunately, if you look at some of the clinical trials, these cells lasted about a year. That's not good enough, because if they start relapsing in a year, and you give them very expensive therapy. So our goal is to try to make CAR T cells more specific, safe, and maybe less expensive.
How expensive is it?
Well, for the commercial products, is almost $400,000 they charge for that. If we produce it locally, it may cost us probably $40,000, but that's what our goal is, to see if we can start making our own CAR T cells.
So what's the usual prognosis for a patient who develops multiple myeloma?
It really has improved significantly. If you look at patients when they were diagnosed 15 years ago, 20 years ago, we used to say, you can live on average 2 to 3 years. Now, I think if you look at patients, depends on their stage.
No.
So if you have stage 1 disease, you would think these patients should live at least 15, 20 years.
Could you tell us what stage 1 is?
So stage 1 is we look at certain things. We look at the chromosomes inside the bone marrow. Are they good chromosome, bad chromosome? We look at something called LDH, is enzymes in the blood. We look at albumin. So if these are normal, and there's another protein we look at the blood called beta-2 microglobulin. So if these are normal and the cytogenetics are good one, that's a stage 1. And these patients, if you look at their 5-year survival, more than 93% are alive at 5 years.
Mm-hmm.
So the stage may, influence how long they live. But we are seeing more patients living with myeloma and starting to die from something else compared to what we did 10, 15 years ago.
What are the other stages?
So stage 2 and 3.
Mm-hmm.
So 3 is the high risk, where you have high beta-2 microglobulin, high LDH, low albumin, and bad cytogenetics in the bone marrow.
Okay. So it's more about the state, like the actual chromosomes and what the cells look like, than how quickly you caught it or how much. I mean, obviously, the metastasizes have a totally different meaning.
Well, yeah. I mean, myeloma is always sort of detected, at a advanced sort of all over the body. So it's unlike other tumors. It's just always systemic disease. But it's, if you detect it at early stage before you have a lot of myeloma, you have a lot of bone destruction, I think you're going to do well. Now, the trick is what we're doing is a lot of research going on is, first of all, as I told you, myeloma is preceded by 2 conditions, MUGUS and smoldering myeloma. So why don't we treat all smoldering myeloma? Because the treatment can have side effect, and we don't know if it really can cure patients. If we have a curative regimen, then we can use it early on and take some risk. So only specific group of smoldering myeloma, which we call them high risk for progressing, half of them will progress to myeloma within 2 years. We're doing clinical trials on them.
Okay.
And there are 2 kind of clinical trials. One used this combination chemotherapy that we have, the novel agents, the monoclonal antibodies, the proteasome inhibitor. We put them together, and what we're trying to do within 2 years to see how many patients are we putting in really solid remission, with the hope to cure these patients. Sure. The other approach to the high-risk multiple myeloma is that can we actually make these myeloma cells visible to the immune system? Can we make the immune system recognize myeloma? And so what we're trying to do is actually generate a vaccine from these myeloma cells and then inoculate the patients with this vaccine with the hope that they develop immunity that will eradicate the myeloma.
So would the vaccine be tailored individually to each patient, or is it the kind of vaccine for everybody?
Yeah, so we take the myeloma cells and generate a vaccine from their myeloma cells.
So is that the kind of thing that's just going to have to be, you think will be commercially, like there'll be a company that does that, or is that where just you need to go somewhere that's doing it in a lab?
I think this should be commercially available. That's the hope, is that you can generate a vaccine that for each patient, you just send the cells and they process it and they send you a vaccine.
Where do you think the most exciting work's being done right now? Or what is the most exciting? What area? I'm not saying where in the country. I mean, what area do you think is the most exciting work?
For me, for example, I am actually looking at trying to figure out, can we prevent the development of multiple myeloma? So I'm doing a clinical trial in patients with monoclonal gammopathy of undetermined significance. And I'm trying to see if we can actually prevent them from developing multiple myeloma. So let me tell you the background of that.
Sure.
So in my practice, I see a lot of monoclonal gammopathy of undetermined significance. And I have seen patients who lost the monoclonal gammopathy. So how did it disappear? So in the 6 to 8 patients I have seen, they lost weight. And by weight loss, they lost the monoclonal gammopathy.
Really?
So we think obesity is an inflammatory state, can stimulate plasma cells. So what we're doing, actually, we're putting a trial together, and we start accruing here. We're going to look at patients who are undergoing weight reduction surgery. Mm-hmm. And what we're going to do is screen them for MUGUS, and then those are positive for the monoclonal gammopathy. We're going to follow them after the surgery and look at the group that lose weight versus the group doesn't lose weight.
Sure.
Are they going to lose the MUGUS or not? So if we can prove that they lost this abnormal protein, that's a good thing. And we're going to try to explore and see why. Is it, because they lost certain inflammatory proteins when they lost the weight or not? And so that will be a great advances.
Is obesity a known risk factor for myeloma?
Yes. If patients who are obese, let me tell you, if somebody has monoclonal gammopathy, and if and they are obese, they have 4.5 chance of developing multiple myeloma compared to non-obese patients. Yeah. So this is a big study that was done at St. Louis VA hospital because they have records on patients who develop myeloma, and they have, they know their weight and they know if they had MAGAs or not. So the obese, 4.5 time chance.
Is type 2 diabetes tied up in that too, or is it just the obesity?
I think it's just the obesity. I haven't looked at I'm not familiar with any data on diabetes, but
so besides the prevention, what else is?
So prevention, I think the other thing is that we really need to screen. I mean, we need to see in this area that we talk about, in the high-risk area, near farming community, near mining community, near factories that was dumping a lot of these chemicals, can we understand how many people do have these pre-myeloma conditions? It will be interesting to understand that. I mean, because then we will sort of study the impact of this environment on these preconditions. And then what we would like to see is a predisposing factor in addition to the chemicals. If you have certain gene, will you get myeloma when you're exposed to certain pathogens? So I think that's exciting to us. And then finally, can we find a way to deal with high-risk myeloma? I think that's really the most frustrating, condition we deal with. And my goal is to really understand the immune makeup of these patients and try to understand how we can enhance it to help us eradicate the disease.
Just because clearly we live locally, how are patients doing here locally, and what are we doing? What kind of studies are we doing locally to try to help?
So that's a great question. As you know, Indiana University issued this Grand Challenge grant trying to really cure 3 diseases in cancers in Indiana. And multiple myeloma was selected as one of these diseases. And so one of the proposal that we have is that we want to understand how myeloma patients do in Indiana. We want to understand their diagnosis, their treatment, their outcome, their side effect. In addition, we want to understand their genetic makeup and also understand the myeloma genetic makeup and the environment. So we're putting together what we call a cohort of patients. We want to analyze 1,000 patients with myeloma and pre-myeloma condition in Indiana. We started actually accruing patients in November, and we have more than 170 patients thus far enrolled. So what we do is we're looking at their sort of baseline genetic informations. We take saliva, we take a blood, and when we do a bone marrow biopsy, we take the myeloma cells and the neighborhood where they live inside the bone marrow cells, and we try to analyze them. And the goal is to try to understand, do they have a predisposition to certain things? What is their immune profile? What's their ability to metabolize certain drugs or not? And then sort of correlate the natural history of the disease with their genetic makeups, the myeloma genetic makeups, and the microenvironment within the bone marrow makeups.
Are you looking at their broader environment as well, where they live, what they might be exposed to?
Exactly. So we are doing that in collaboration with a group down in Bloomington because, by zip code, you can figure out where they lived, what they exposed to, and things like that. And we have survey that we ask the patients to help us understand, their occupations and where they grew up, things like that.
So how long do you think that'll have to take to get all the patients you want?
So as you see, since November, that's about 5 months. We have 170 patients. So I'm hopefully we can accrue all these patients within 2.5 years.
Are those all new diagnoses, or are those just patients you're picking up?
Our patients, from newly diagnosed relapse patients.
How common is myeloma to begin with?
So myeloma is about 1.5% of all cancers. And we're trying to figure out the exact, incidence in Indiana. It's probably about 1,200 new patients diagnosed a year.
Clearly, the NIH has to, give money to this, but how else do you put money together? Are there foundations? How else does myeloma research get done?
As an avid runner, about 15 years ago, we were sitting with patients and trying to figure out how we can, sort of support myeloma research at Indiana University. So one of my patients said, why don't we just do 5K for myeloma? And I said, well, everybody has a 5K for myeloma. How about we do something different? You guys come to me from all over Indiana for a second opinion. Why don't you go to your community and spread sort of word about the disease? And they said, wow, that's exciting. So but I'm not going to be riding a car to go there. I'm just going to run, And the first year, I wanted to go run to Fort Wayne.
Okay.
But that was a huge,
That's far away for people that don't live in
and I
Indiana,
said,
yeah.
I'm not ready, So what we did is we sort of, in the first 4 years, we split it, 1 day of running and 1 day of cycling.
Okay.
So we did about 50 miles of running and the rest is cycling.
Still a lot of running.
So that's how Miles for Myeloma started. And then, because the distance started getting like 200, 250 miles, it's just 2 days or 3 days of cycling.
Okay.
So we have come from St. Louis to Indianapolis, from Columbus, Ohio to Indianapolis, Miles for Myeloma. We have raised almost $5 million. But the most exciting thing about the whole thing is that we have patients who ride with us.
Right.
It's organized by family of patients that do that. And so the thing about it is that makes me really excited is that to see myeloma patients riding.
Yeah.
And I still remember one day, because, you get these guys who wants to ride with you and they're very, really amazing cyclists and they just, this is not a race. This is a group of people trying to ride together to support each other and spread the word about myeloma. So if you have, somebody, already in Indianapolis and the other person is still in Terre Haute, it's not fun.
No.
It's hard. So I remember one time it was like, I want to, tame the group down a little bit. So, I stopped everybody and I said, do you know why we're doing this? Because of myeloma. What are we going to do about it? We're going to spread the word. We're going to try to raise awareness. We want to make sure that everybody understands this disease need to be cured. So I said, how many of you riding with myeloma today? And there were 2 people. Mm-hmm. And I said, how many of you riding, with myeloma and still on treatment for myeloma? 1 guy. I said, okay, so this guy is going to lead us. And everybody has to follow him.
Right.
Do not pass this guy. So I was kind of probably doing it because I was tired.
Right.
I want to slow the pace down a little bit. So this guy grabbed a bottle of water, poured it over his head, and we actually stopped at the bottom of a hill. And this guy was climbing so fast, I was like working hard to stay with him. And I said, oh my gosh, why did I say that?
Right.
But it was amazing to see how excited he was, how aggressive he was climbing that hill. And it just makes me know that, today myeloma patient can live a normal life. It's not, a disease that stops you from living your life. And that's why we need to tailor the therapy so they can live healthy, quality life. And hopefully we can find a combination that cure them so they don't stay on treatment forever.
This Healthcare Triage podcast is sponsored by Indiana University School of Medicine, whose mission is to advance health in the state of Indiana and beyond by promoting innovation and excellence in education, research, and patient care. IU School of Medicine is leading Indiana University's first grand challenge, the Precision Health Initiative, with bold goals to cure multiple myeloma, triple-negative breast cancer, and childhood sarcoma and prevent type 2 diabetes and Alzheimer's disease. Thanks again to our guest, Rafat Abonour, for our discussion of multiple myeloma, what causes it, what we're doing about it, and where things might be going in the future. Listen to the Healthcare Triage podcast each and every month for information about health policy, health research. We'll see you next month.